Hi, thank you for joining. My name is Erez Baruch, and I'm from the Lemelbaum Institute for Immuno-Oncology in Israel. I wanted to share with you our recent findings about a new toxicity of anti-PD-1 therapy. Diarrhea is a common symptom among anti-PD-1 patients. Management can range from symptomatic to immunosuppressive drugs. But what about the differential diagnosis of diarrhea in these patients? Well, as we can see here from the screenshots from up to date, diarrhea is virtually a synonym to colitis, and there is no other drug-related diagnosis that is possible in this patient or that has been reported for these patients. But is it really reasonable that anti-PD-1 therapy, a therapy with such a profound effect on so many different systems of our bodies, has only one etiology? This didn't really add up for one of our patients. Patient H is a 30-year-old male who underwent anti-PD-1 therapy in the adjuvant setting. About 9 months into therapy, the patient developed severe diarrhea, which was clinically diagnosed as colitis. The diarrhea was steroid resistant, and the anti-PD-1 therapy was stopped. The patient has undergone a rigorous workup, but all tests were negative, and the diarrhea continued. So we went back to basics and reviewed his medical history. On diarrhea-oriented questions, the patient reported foul-smelling stools in large amounts, highly correlated to fatty meals, which were suggestive of steatorrhea. When reviewing his CAT scan, our radiologist, Dr. Eshet, has noticed that the patient's pancreas had undergone a significant atrophy. Fecal analysis tests have confirmed the diagnosis of steatorrhea, and indeed, when was administered with pancreatic enzyme supplements, all symptoms resolved. This case made us wonder, are there any more patients like patient H, or what's the occurrence of pancreatic atrophy among anti-PD-1 patients? And another question is, does any case of pancreatic atrophy may lead to exocrine pancreatic insufficiency and steatorrhea? We reviewed the medical records and consecutive CAT scans of almost 200 anti-PD-1 patients. We identified 3 groups. The first group composed of patients with radiological evidence of pancreatic atrophy. The second group composed of match-control patients, and the third group was composed of patients with a recorded diagnosis of colitis without pancreatic atrophy. We measured the pancreas volume in each CAT scan for each of these patients in all 3 study groups. And we calculated a new parameter called atrophy rate. Atrophy rate is the ratio of decrement in pancreatic volume over time. We found 16 patients with pancreatic atrophy, and this atrophy was attributable to the drug. Among these 16 patients, 2 of them had developed exocrine pancreatic insufficiency, which was responsible for about 10% of all cases of diarrhea among our cohort. Interestingly, the degree of atrophy didn't correlate to symptoms as similar to other anti-PD-1 adverse events such as pneumonitis. The radiological and clinical onset of pancreatic atrophy and exocrine pancreatic insufficiency was about 9 to 10 months into therapy, whereas the onset of colitis was about 2 months into therapy. Among the patients with pancreatic atrophy, no new diagnosis of diabetes mellitus was done. The mechanism of pancreatic atrophy is unclear. It may be due to recurrent or chronic pancreatitis, as similar to pancreatic atrophy due to alcohol abuse. However, blood amylase and lipase levels were not suggestive of pancreatitis. Only part of the patients had radiological evidence of pancreatitis, and only 1 patient reported upper abdominal pain and nausea. It may be possible that other mechanisms participate in this atrophy, such as anti-endothelial damage induced by T cells, which may lead to an indolent vascular injury to the pancreas. In summary, anti-PD-1 therapy can induce pancreatic atrophy, which may result in exocrine pancreatic insufficiency. This insufficiency is a distinct differential diagnosis to colitis, and we should suspect this situation in cases of late-onset diarrhea with characteristic of steatorrhea, diarrhea that is resistant to steroids, and when the patient has radiological signs of pancreatic atrophy. Symptoms will be resolved with administration of pancreatic supplements. However, as it seems now, the atrophy will be irreversible. I would like to thank all of the co-authors of this study, especially Dr. Yael Eshet, Dr. Jacob Schechter, and Dr. Gal Markel. Thank you for watching.